Hear me. All right.
Okay, can everybody hear me?
Yes, I can.
Oh, good. Okay, and then you all should be having a view of not me, but my PowerPoint or my PDF, right?
Yes, we can see it.
Okay, so I think I'm going to go ahead and get started. So I reviewed an article called Evaluation and Management Outcomes and Burdens in Patients with Refractory Chronic Cough, referred for behavioral cough suppression therapy. So why did I choose this article? I feel like there's a lot more education needed on chronic cough, and I feel like this was a good introductory sort of study. So I felt this provided a good introduction. I think all rehabilitation disciplines have potential patients with cough and have the ability to better manage the chronic cough population with their referral recommendations and also with the feedback that they're giving patients if patients have this symptom. I also think it has significant impact in spending outcomes on insurance. It has significant outcomes for quality of life for patients, and it benefits our rehabilitation departments, and it impacts. I also liked this article because I felt like it also influenced me. I've been treating chronic cough, but I felt like there was some good stuff for me to learn from the article. So I want to talk a little bit about terms before we get started. In the introduction of the article, she does define, or the primary researcher, the researchers define chronic cough as a cough that lasts more than 8 weeks. If a cough is lasting more than 8 weeks, there's 5 possible diagnoses of the cough. There's upper airway cough syndrome. There's cough variant asthma. It could be gastroesophageal reflux disease or eosinophilic bronchitis. And then there's a 5th option, which is the one we're going to talk about today. It could also be what we're going to call, and what this article calls, refractory chronic cough. So when the aforementioned chronic cough types on the previous slide that I went over have been evaluated and they are found to be absent, or they have been treated adequately, but the cough persists, then we have what is defined as refractory chronic cough. Refractory just means stubborn or unmanageable, resistant to a process or stimulus. Sometimes chronic, initially when I was introduced to this topic, refractory chronic cough, I just referred to as chronic cough. So it does have different names in the literature. I've heard recalcitrant, I think is another word I've heard, recalcitrant chronic cough or something like this. So you may hear other names for this, but in this article, it's called refractory chronic cough. And then another thing in the title, it mentions behavioral cough suppression therapy. So I wanted to talk a little bit about that. The goal of behavioral cough suppression therapy is to use cognitive behavioral techniques to override your cough reflex, and by doing so, to improve your ability to control your cough and to reduce your cough sensitivity. So when they talked about treatment for this population with behavioral cough suppression therapy, the bottom line was they were using some sort of cognitive behavioral technique so that patients would reduce their cough sensitivity and improve their cough control. And then this therapy, the behavioral cough suppression therapy, is administered by speech-language pathologists who subspecialize in disorders of the larynx or the upper airway. So the study questioned, they wanted to investigate the medical management of this population in adults with refractory chronic cough that were referred to as speech-language pathologists in order to estimate the cost effectiveness and the efficiency of the current practice patterns for this population. This is a cross-sectional study because it's an observational study that analyzes data from a representative subset at a specific point in time. And so some of the questions that they asked were things like, how long have you had refractory chronic cough? How many doctors have you seen for the problem? So our patient problem is what are the typical symptoms, what's the medical management, what's the cost effectiveness, and what's the efficacy of our current practice patterns for the population. So we had 164 patients with refractory chronic cough that were referred for behavioral cough suppression therapy, and they were surveyed at the beginning, end, and throughout their treatment. Patients completed an initial survey at behavioral cough suppression therapy onset related to their symptom pattern and prior treatment. This included the Leicester Cough Questionnaire, which you could look at. I feel like it's a pretty extensive questionnaire that asks some very specific questions about their cough. And it's a way for us to measure, as speech-language pathologists, how bad their cough is and how much they're responding to treatment. So this was given every 4 to 6 weeks. Patients were completing follow-up surveys to assess their response to behavioral cough suppression therapy. So I just put here a couple of the tables and figures that were included in the article. In figure 1 with the blue vertical lines, you can kind of see they surveyed the patients what medications had they been prescribed prior to being seen for behavioral cough suppression therapy. So this was a time when the patients were still trying to address their cough, and they were given medications that eventually either didn't work or didn't work enough, and they sought further treatment from speech-language pathologists. And you can see the very most frequent medication was for postnasal drip. That's what the PND stands for. And then in table 1, it kind of shows what type of population it is, what age, what the gender was of the patient population surveyed. At the very bottom of table 1, you see numbers 1, 2, 3. Those are how many physicians the patients had been referred to that they surveyed prior to being sent to a speech-language pathologist. And then there's also in table 2, they go through some of the scores from the Leicester Cough Questionnaire that show a significant difference in response to behavioral cough suppression therapy. So most patients sought care. When they analyzed the data, they found that most patients sought care from at least 4 physicians prior to being referred for behavioral cough suppression therapy. Most patients trialed 6 different medications intended to treat cough before they were referred for behavioral cough suppression therapy. And given that the average wait time in the United States to see a physician is 24 days, and pharmaceutical treatments require 1 to 6 months to determine their effectiveness, there's a significant health and financial burden for delaying the introduction to behavioral cough suppression therapy. They did comment in the article, they said some of the pharmaceutical treatments that directly targeted cough hypersensitivity had been helpful in a portion of the patients with refractory chronic cough. However, as we saw in this particular case, many of these patients went on to seek behavioral cough suppression therapy because they didn't get a good enough response to these pharmaceutical treatments. So behavioral cough suppression therapy in the patients they looked at was more effective than pharmaceutical treatments. Also, we should consider behavioral therapy has a much lower risk profile than a pharmaceutical treatment because you could always have side effects from pharmaceutical treatments. We don't know what other medications the patients may be on. There could always be a reaction with those as well. So the researchers also were very interested in the cost effectiveness because, of course, if you're seeing 4 specialty doctors before you're getting treatment for your cough and you're trialing 6 medications, that's a lot of money that insurance is being billed prior to really being able to decrease or eliminate your cough. So I know the primary researcher is from Montana, so I don't think these numbers are probably accurate for our state, but there's a lot that is often going in financially, tests that patients are completing as they're trying to figure out why this patient has a cough and how to treat it successfully. So the results of the survey suggest that earlier intervention with behavioral cough suppression therapy may be a much more cost-effective and efficient option for patients with refractory chronic cough. So how does this topic relate to our patients? I don't know what you guys are seeing, but I know I've had patients say some of these things to me. I've had patients come into my office and warn me that they have a cough, but they're not sick. That happens frequently. And I think that's a little bit of a red flag for me. Another thing I've heard patients say, which is another huge red flag, is if they say, my cough is lingering so long, my cold ended a month ago, 2 months ago, 3 months ago, but the cough is still lingering. I still have it. So all of us see patients who experience cough. However, appropriate and effective treatment for refractory chronic cough is obviously unknown to a lot of practitioners. A lot of people don't know that speech language pathologists who subspecialize in this population can help them significantly. The topic helps us understand that refractory chronic cough exists and that there's a most effective treatment for it. So the main objective would be early intervention with behavioral cough suppression therapy is cost effective and efficient for these patients. So I really like this slide because you don't necessarily, when somebody has a cough, want to refer right away, first thing, for behavioral cough suppression therapy. We do have to rule some things out so we make sure we're actually treating refractory chronic cough. So it's best to promote behavioral cough suppression therapy following the rule out of what we would call, number one, just major red flags for one of those other diagnoses. So we want to rule out any, if it's a productive cough where there's like sputum coming out actively in the cough, if they have a history of heavy smoking, prominent dyspnea at rest, if they have hoarseness, if they have symptomatic symptoms, if they have dysphagia, if they have vomiting or a recurrent pneumonia. We also definitely want the patient, before they're treated for cough suppression therapy, we want them to have a normal chest x-ray. We don't want this cough to be due to a lung pathology. So in this article, they say if we do these two things first. Oh, I'm sorry. Is somebody saying something?
Yeah, I have a question.
Oh,
Did
go
you
ahead.
say what the first one was? What after red flags? What is
Red
that?
flags.
After, yeah, the word after red flags.
Oh, I didn't say that one. It's hemoptosis. I'm not sure if I'm pronouncing it right. I didn't read that word, but it is
What
also
is it?
that is one of. Oh, I'm not sure. I'm not sure what that is.
Oh, okay. Okay.
Oh, coughing up blood, I think. Yeah.
Yeah,
So if they're
hemoptysis
coughing
is
up
coughing
blood,
up
don't
blood.
refer for cough suppression therapy.
Got it. Okay. Thank you.
Yeah. Thank you. I think that was a great question. And then anyway, so I would think a primary care doctor could actually do both of these things, could rule out the red flags and probably order a chest x-ray to make sure that it's negative. So strengths and limitations of the study. First, I want to talk about some potential strengths. In the speech language pathology population, sometimes the populations we're looking at are very small. I think 164 patients is relatively small, but for us, that's actually quite a few chronic cough patients that they were able to look at for this study. The speech language pathologists were from 13 clinics across 6 different states in the United States and 1 hospital clinic in Australia. So it was the location of the population was very diverse. And it also measures response to treatment using the Leicester Cough Questionnaire over approximately a 3-month period. So I like that they had a questionnaire that's been created for cough that they were able to use and measure and be consistent. What about the limitations of the study? Maintenance of results from treatment, I don't really feel like they were adequately assessed in this population. They looked at about a 3-month period, and I think what my understanding is a placebo lasts about 3 months. So it would be nice to see if there was maintenance of the results of treatment beyond 3 months. And all the data that we're getting is based on patient reporting. So that's not always 100% accurate. It's not a totally objective measure. And the population tested was predominantly white, at least 66%, because we had many, I think about 20% of the participants didn't say what their ethnic background was. So it could be higher than 66%. And a significant portion of the population was female. They had 83.5% were female of the patients that they looked at. I think also this article doesn't seem preoccupied or interested in the cause. So personally, as a clinician, I really would like there to be more focus on what's causing this. So that we don't have this behavior reoccur. If we understand what caused it in the first place, I think that can prevent it in the future. Also, I kind of didn't like about this study that I felt like they were looking at a lot of different things. They were looking at the response to treatment, the efficacy of the workflow, typical symptoms, the cost effectiveness. I feel like it would have been a little bit of an easier study had they just kind of focused on one of those or maybe two of those measures. So next thoughts and questions or ideas for future studies. We could do randomized controlled trials to determine the role of first-line medical and behavioral and combined medical behavioral therapies in improving objective measures of cough and quality of life. And then outcomes and practice changes. I think there could be definite referral practice changes. I think referring maybe to either pulmonologist or PCP. And then after that, considering, you know, once we've ruled out some of the red flags and the chest x-ray being negative, then referring to behavioral cough suppression therapy. So hopefully it changes our workflow. I think I would like there to be more involvement of speech language pathologists in treatment of refractory chronic cough. I'm afraid that these patients are often not really getting the treatment they need because medical practitioners don't know about this treatment and appropriate background knowledge to make the correct referral or the correct referrals. So here's my references, and that's pretty much it. Are there any other questions?
Interesting. I want to know, so what kind of behavior like therapy do you do for that?
Right. Ingrid had a really good question. She's like, okay, so we're doing behavioral therapy. What behavioral therapy are we doing? And I have heard clinicians using very different behavioral techniques to suppress the cough. I know what I do, and it's actually different from I heard about this study from the primary researcher, and she does something different. So what I typically do is I have the patient do diaphragmatic breathing with a focus on not using upper airway musculature. I try to put all their attention on sort of movement on their abdominal wall while they're breathing. This takes a lot of the attention off of their upper airway muscles. I feel like there's some sort of vagal response happening. And somehow when we calm the muscles in the upper airway, we're suppressing some of that vagal urge to cough. I believe the primary researcher, I'd have to go back and look at her notes, but she did something more like she basically tells the patients, when you feel the urge to cough, you need to not cough. She doesn't give them like a behavior to change. She just says, don't do it. And I think she may even have them like sit in a chair. Other clinicians could have different things that they try to do, kind of like when you have the hiccups and somebody comes in and scares you. It's like it's working for a reason. Sometimes we don't always understand exactly why that's working. So they'll give them another behavior to focus on to suppress the cough. I think in this study, it was about 87% effective, the behavioral cough suppression therapy, and they did have a lot of different researchers or a lot of different clinicians from different states all doing different things. I feel like when I've seen patients using diaphragmatic breathing, I see really positive results. However, I did see a patient with dementia or onset sort of dementia. And it was extremely hard for her because, of course, with a behavioral therapy, she's not very good at recalling the practices that I was telling her. So that was a little bit of a trickier population for me. Yeah.
So would like patients like COPD or pulmonary fibrosis, would they also benefit from something like this?
Yeah, Claudia had a really good question. She said, what about patients with like COPD or pulmonary fibrosis? I think potentially if it's a dry cough that's just getting triggered very easily, I think they could. And I feel like I've had patients diagnosed with like asthma and it almost sometimes seems to go away, the asthma, with changing how they're breathing. So sometimes I wonder, was it really asthma? Was there some sort of vagal response going on here? I don't know. Yeah. Any other questions?
Marilyn, I had a question.
Uh-huh.
Can you go back to like towards the beginning of your slides, where you were defining what the refractory chronic
Oh, yeah.
cough was? Was there a certain time frame that passed before it was diagnosed as refractory chronic cough?
That's a very good question. Let's go ahead. I think in some of the figures, a slide with the figures. So if we look at table 1 all the way on the right, if you go kind of middle bottom, it's going to say length of cough. The maximum length of time they put on the questionnaire was 24 months. So we see about 51.8% of the patients surveyed had their chronic cough for at least 2 years. That's pretty significant amount of time to have a chronic cough. And I think that's also, just from my personal experience, what was very motivating for me to do this article. You can see some patients were referred, I think 11% after 2 to 4 months. So they got a very quick referral, but on the whole, the first refractory chronic cough patient I ever saw, probably about 10 years ago, had been coughing for 10 years and had to quit his job and retire early because he was coughing on people and he worked with people. So he couldn't find a way, and his cough wasn't, in that 10 years, he saw a lot of different practitioners. He even did see a speech language pathologist, but that speech therapist didn't know how to treat his chronic cough. So after 10 years, I worked with him. His cough went away. It was a very dramatic outcome for his life.
That's really amazing, Marilyn. Kudos to
Right.
you, and kudos for this topic and you having that training, because I've talked with you a lot about it, you and I, and I find it very interesting. But I was just wondering, like, I see what's like in the chart, but I was wondering how medically they define it. Like, is it got to be a cough that's more than 3 weeks, a month? I'm not sure if you said that at the beginning.
That's a really good question. So they define it in the article, and I'm assuming there might be citations.
More than
they have
8 weeks.
Right, more than 8 weeks. However, they were saying chronic cough, that there's basically 5 types of chronic cough, with refractory chronic cough being only one. So we have to rule out the other cough types, because we want to make sure the patient doesn't have asthma, or that it's not a cough happening because the patient's refluxing and their body is very appropriately trying to get rid of the reflux and producing a cough. Sometimes I have treated chronic cough patients who did have, and I think sometimes that was the onset, what led to their chronic cough was just having a history of reflux.
Yeah.
I have a question.
Yeah. Oh, did you have another question, Cindy? Alicia has a question too.
Yeah, I remember when you and I were talking, I just thought what was an interesting point that I think you and I talked about in the past was you were saying that some patients, when they're swallowing and they're coughing, but they're not actually aspirating, would they fall into this category, or is that different?
No, I think that's a really good question. Those patients are usually, if the cough is around the swallow, I wouldn't treat that patient as a chronic cough patient, because it's somehow triggered to their swallow and a protection of their airway that's happening when they're swallowing. So generally, I'm going to look more at if it's happening just around the time they're swallowing, there's usually something else going on. They could be hypersensitive. Sometimes we have to train patients that, like, when we're doing like a modified barium swallow, you're coughing, but you don't have to. You're being a little hypersensitive. But if it's only happening while they're eating, it's kind of the same idea. We tell them suppress your cough, you're okay. So it's kind of the same as behavioral cough suppression therapy. But I don't know. I've thought of them more as like maybe dysphagia or something going on with their swallow, but it could be a hypersensitivity. I don't know.
Okay,
I don't think that really answers it, but that's maybe a trickier patient If it's just happening around swallow, then it's got to be related to the swallow somehow for them.
Yeah, you
Alicia
answered it.
also,
Thank you.
oh, go ahead. Yeah, Alicia also has a question.
So when I'm listening to behavioral interventions, I know at least in pelvic floor therapy, we have a lot to sort of override the sort of natural impulse around bladder care. And some of the things we do are like dig your finger into your thumb pad to distract the brain. Like lift up on your heels, triggering the calves for at least the bladder is the same nerve root.
Right.
I'm wondering if there are some strategies that would make sense in regards to calming down the upper airways when they feel that urge to cough. And then my other thought is real quick that sometimes I do think that people think, oh, I feel the cough, therefore I have to.
Right.
And no one's ever told them before that, you don't have to.
Right.
And it seems like it would be something obvious, but I do feel like that could be very powerful for someone who is a medical professional with authority to say, no, you don't have to do that.
Right.
I see that with bladder too. Just because your bladder tells you you have to go doesn't mean you have to go.
Yeah.
So
no, I think
what are your
those
thoughts on that.
I think those are really good points. Could you guys hear what Alicia was saying?
Yes.
Okay,
Yes.
good. So yeah, Alicia had, I love the way she was talking about the behavioral treatment for bladder. We're kind of just doing the same thing, I do think, for the upper airway. Like when she was saying, squeeze your thumb into your, the pad in your hand. That might not be the same nerve that controls bladder, but you're putting their attention somewhere else. And in the same way, I feel like when a patient's maybe watching their diaphragm move, their attention is moving from their upper airway to their abdominal wall. But also, I think there is a component of possibly a nerve that is hypersensitive or aggravated, the vagal nerve in the case of the cough. So I do think the diaphragm also has the vagal nerve. So you're kind of giving a job to that nerve to do rather than cough. So, and I feel like what she was describing with like engaging your calves to control bladder is kind of a similar idea. I do feel like it's really very similar. And she also said, it can be, some people just feel like coughing and they don't know that they can suppress it. And I think that's true. For these patients, I think the total number of visits that they had was 4 or 5 visits. So that's not a lot of treatment with sometimes some very dramatic outcomes. Like the patient I had that coughed for 10 years. And then I can't remember how many treatments I did. It was probably 4 or 5, maybe 6 treatments. But that's pretty dramatic to only need that amount of treatment for such a big outcome.
Yeah, and then also, I know we get, as pelvic floor physical therapists, we get referred a lot of patients who have bladder issues when coughing, and occasionally it is a chronic cough. So if we have patients who we want to refer to you, what do you think the best way to do that is?
I love that. I would love to get more referrals. I do feel like here at Providence, I get less referrals because before I was in an ear, nose, and throat clinic where I think that they were seeing more chronic cough patients and then directly referring to me, who was just across the hall. Whereas here at Providence, I don't know that physicians know we can treat this. I think, what I would probably do if you have a patient who you feel like is a chronic cougher, it would be great if we could reach out to whatever physician referred them and say, if they find out if they've gotten a chest x-ray, if they have, and they're telling you it's negative and they can't figure out their cough, I would say, have you seen your primary care doctor? Are you coughing up blood? And if they've seen their primary care, I would probably reach out to their physician and say, I believe this patient would benefit from a specialist for chronic cough therapy. Would you mind referring them to CJOPROV, etc.? I always put the code when I tell the doctors that I want a referral because that helps them know exactly where to send it. So I put our code for outpatient Providence in the message to the doctor. Okay, we have 2 more minutes. So
everyone who is in the chat, not live, can you put your name down in the chat? So just for attendance purposes.
And Marilyn, this is Allie over at Inpatient.
Uh-huh.
Hi, this is Allie at Inpatient.
Hi.
Can you?
Yeah,
You
yeah.
know, I was wondering, Marilyn, if you can send the presentation or if this will be available, because I know Kelsey wanted to
Okay.
get in on, but she wasn't able to, but she would love
Okay.
to watch the presentation.
Yeah, I don't mind at all. I can email her.
Also, we're gonna put it on YouTube and set up a link.
Right. So
Got
she,
it.
To watch it,
Yeah.
all of this.
yeah, she could
Great.
watch the recorded. Yeah.
And
Thank
that's
you,
like all
Ally.
the Discussion too.
Yeah.
And I'll send
Marilyn.
the PowerPoint with the link to the actual video recording.
Yeah. Was someone else was going to say something, I think?
Oh, I was just gonna say that this is a very interesting topic and thank you for sharing your expertise with us.
Oh, thank you so much, Cindy. I definitely feel like these patients are out there and not getting treatment. So I think it'd be great, you know, if you're wherever you are, you hear somebody with it, if you can provide them a little bit of feedback that just that they need that chest x-ray and to talk to their doctor, and then maybe cough suppression therapy might be the way to go. And then I do want to say I am going to be presenting next month also. I haven't selected an article yet, but what I really am trying to look at, I'm also very interested in hormone replacement therapy for, you know, patients that are delaying the onset of puberty because maybe of some gender dysphoria. I feel like that could affect us because, of course, puberty changes the body and hormones change the body. That was another topic in speech. You know, it changes your vocal cords and the way you sound. So I'm hoping our next month topic will have something related to that. Okay, I think that's all. Thank you so much.
Thank you, Marilyn.
You're welcome. Or stop.